And we are. All right. So last time we did all the intro fun. So then this time we'll get into some basic anatomical directions, and then we'll talk about movement in planes, and then time permitting we'll talk about some different body cavities, which is not as gross as it sounds. All right. So one housekeeping thing. So last time emailed me and asked about the book. She said she'd gone to the bookstore and that they didn't have it. And yeah, she's right. I messed up. So remember last time I mentioned that this class used to be one big whole body called 271. Well, if you're just keeping the same book, as far as textbook rental goes, you don't submit a new request. And then I forgot that this is technically a new class as 201, so I didn't put in a textbook request. So there's not a book at the bookstore. But I did put in a textbook request yesterday. And so the guy who's in charge of that, his name is Mike, who does textbook rentals, said that they should be able to get the 10th edition pretty easily. So it sounds like in the next few days that the previous edition, the 10th edition, will be available for rental at the bookstore. So once I hear back about that, I'll let you know. Yep.
So it's not this one then?
It is, yeah, so that's the one that they'll have.
Okay,
Yep.
It's there.
It is.
It's just off to the side. It's not like on in the actual,
Okay.
like, can't think of like what's called the area.
Okay.
It's in the next one right there.
Okay.
Yeah.
So if you see a big tan anatomy textbook with Chris Paul on the front, that's the one you're looking for. So that'll work. If they eventually get the one with the gymnast on the front, whose name escapes me, I think it's Simone Biles, on the front, then that's cool too. But either way, the 10th edition works. Yep. Okay. Awesome. Okay. I didn't know because I'm not 100% how y'all's fees work because I know it's somehow built into the course fees and all that stuff where it's free. So I'm hesitant to suggest to get it from somewhere else. But if you want to go that route, then certainly feel free to do that as well. It's a lot better than the $500 a book we used to have to pay. So, but thanks. I appreciate that. All right. So anyway, that's the book. So like I said, if I hear anything else from the bookstore, I'll let you know. All right. So moving on, we're kind of doing a blend of chapter 1 and some other material. So I don't remember if this picture's from the book or not. I think it is. So one of the things when we start talking about the shoulder on Wednesday is I'm going to throw a lot of anatomical terminology at you. I'm going to talk about superior, inferior, medial, lateral, that kind of stuff. And so to help that make a little bit more sense, we're going to go over that today. But our starting point is with this, which is anatomical position. So anytime we're talking about directions on the body, our reference point is someone who is positioned like this, which is referred to being an anatomical position. So they are standing, their ankles are in a neutral position, their palms are facing forward, which is called supination. So this is normal anatomical position. So when we talk about movement, as we're going to, we're assuming that this is their starting point and they're moving from here to, let's say, here with shoulder flexion. So in shoulder flexion, you take your arm and move it straight forward from anatomical position. So again, this is our basic starting point when we're talking about any of our anatomical directions. All right, so let's talk about some specific terms. The first two on there are superior and inferior. A few things to know about them. The first is that superior means higher up or closer to the head. Now, if we're talking about something on the head, obviously superior just means closer to the top of the head. But superior is something that's higher up on the body. And you can think about it in terms of if you have a product in business. If it's a superior product, it's higher ranked, it's better, it's closer to the top, right? So anything superior is higher up. Anything inferior is worse, not as good, lower ranked, etc. So that's lower on the body. And so one of the things that I want to emphasize about these two terms is we use those when we're describing things on the head, neck, and trunk. So we don't typically use superior, inferior on the arms or legs. So we're just talking head, neck, and trunk here. So for example, you might say that my nose is superior, so higher up, than my sternum, that bone in the middle of your chest. And then you can just flip them. Sternum is inferior to the nose, right? There's some alternative terms there in parentheses that we'll use some, but not much. So you can see the alternative term for superior is cranial. So obviously your cranium is your head. So anything cranial is closer to the head. Caudal refers to tail. So think about your tailbone. So anything caudal is closer to the tail. So you'll see that sometimes in physical therapy literature. They'll talk about like caudal glides and things like that. But anyway, it means lower down. All right. Then we've also got anterior and posterior. So anything anterior is closer to the front of the body. Anything posterior is closer to the back of the body. And there's two alternative terms on there as well. So anterior, the alternative term is ventral. Posterior, the alternative term is dorsal. So when we talk about body cavities here in a little bit, we're going to talk about dorsal body cavities, which are on the back of the body, and ventral body cavities, which are on the anterior or front part of the body. So for the most part, though, especially when I'm talking, the terms that I'm going to use are anterior and posterior. So anterior front, posterior back. Then we got medial and lateral. So anything medial is close to the midline. So you have an imaginary midline that runs through your nose, your sternum, and your belly button. And so anything closer to that midline is referred to as being medial. Anything farther from that midline is lateral. So you'll see those two when we talk about, like on Wednesday, there's two tubercles on the proximal aspect or on the close aspect of the humerus. One's medial, one's lateral, so they'll come up when we talk about that. And then proximal distal. So proximal distal are similar to superior inferior, except that proximal distal are terms that we're going to use on the arms and legs. So anything proximal is closer to the body. Anything distal is farther from the body. So distal sounds like distant, and then obviously distant is far. And so anything distal is far from the body, so then proximal is close. So for example, we're thinking about your arm. So your elbow is proximal, closer to the body, than your wrist, or proximal to your wrist is probably the better way to say that. Conversely, the wrist is distal, farther from the body, to the elbow. And then we'll get to the two in a second. Superficial and deep, those are a pair. And so anything superficial means shallow. So a superficial, closer to the skin surface. Anything deep is farther from the skin surface. So this is going to come up when we talk about layers of muscle. So for example, with the shoulder, one of the layers of muscle, or two of the layers of muscle we'll talk about, in your chest, you've got a big superficial, so close to the body, chest muscle. So that's your pectoralis major. That's the one that's pretty obvious. And then there's one underneath it, or deep to it, that is pectoralis minor. So we'll use superficial and deep when we talk about different layers of muscle. We'll talk about that actually a lot in the forearm. We'll go through several different layers of muscle there. So superficial, close to the skin surface, deep, farther from the skin surface. And then the bottom two on there, you might be familiar with from video games. So if you are lying supine, that means you are face up. So you're lying on your back. If you're lying prone, you're face down. So you're lying on your stomach. So supine, laying down but you're face up. Prone, laying down but you're face down. So, and I don't know if it helps or not, but remember that if you're in anatomical position, again, I mentioned that your forearms are in supination, which means that your palms are facing anteriorly or facing forward. And so typically the way that's described in anatomy classes is that supination is like you're carrying a bowl of soup. So if you bring your hands forward like this, if you're going to carry something, so that's supination, as opposed to pronation in the forearm looks like this, right? So facing backwards. So if your palms are facing up, they're supine. If you're facing up, you're supine. Like I said, I don't know if that helps or not, but it's one way to remember it. All right, so let's talk about planes of the body. So what planes of the body are effectively imaginary lines that divide the body into segments. So there are three planes that we'll talk about. The first plane that you can see on there is the sagittal plane. It's got one G and two T's. I almost always misspell that and flip those two. But the sagittal plane is an imaginary line. That's the one that's pictured there on the slideshow now. The sagittal plane is an imaginary line that runs through your nose, through your sternum, through your belly button. It's the one that I described earlier when I was talking about medial and lateral. So it's this imaginary line that divides the body into left and right. And one of the things to know about planes to make life a little bit more complicated is that there are an infinite number of planes. You can slice the body an infinite number of times along that imaginary line. And so the one that runs directly through your midline is referred to as the cardinal sagittal plane. And so that's the one we'll talk about most of the time. But the fact that there are an infinite number is going to be important here in a second. So the sagittal plane, the thing to know for now, is that it divides the body into left and right, or medial and lateral. The frontal plane, which is the one that's up there now, that one's pretty easy to remember, because that one divides the body into front and back, or anterior and posterior. And so the frontal plane is also an imaginary line through your ear, down through the tip of your shoulder, through your hip, and then all the way down. So again, that's going to divide you into front and back, is the frontal plane. And then the last one on there is the transverse or horizontal plane. And I apologize in advance because I flip back and forth on what I call it all the time. Sometimes I call it transverse. Sometimes I call it horizontal. It's not intentional. But both are correct. Either one works. And the transverse or horizontal plane looks like this. So it divides the body into top and bottom, or superior, inferior, or proximal, distal, depending on what we're talking about. So those are the three planes. Now, where life gets complicated is when we start talking about movement in planes. So you can see a term up there, osteokinematics. Osteo is bone, kinematics deals with motion of. So when we're talking about motions that we can easily observe, so if somebody does what's called shoulder or glenohumeral, so your shoulder joint, the primary joint's the glenohumeral joint. Talk about that on Wednesday. But if somebody does glenohumeral or shoulder flexion, what that looks like is they take the palm of their hand and they come straight forward with their arm straight. So right now I'm doing glenohumeral flexion. So that's something that all of you can see. You can see that my humerus, my upper arm bone, rotated around the glenoid cavity, which is the socket on my scapula, on my shoulder blade. And so it's really big, obvious motion. So that's osteokinematic motion. That's as opposed to arthrokinematic motion, which you don't need to write down now. We'll talk about it with the shoulder. But arthrokinematic motion are these really small movements inside of the joint where the two bones will roll, slide, or spin on each other. So osteokinematics are what we're talking about now, these really gross in terms of being large, readily observable movements. So we can describe osteokinematics then in terms of the planes of motion in which they occur. So, for example, going back here, with the sagittal plane. So remember that divides us into left and right. The cardinal sagittal plane runs right down my midline. But if we take a sagittal plane that runs through the middle of my shoulder joint, again, the middle of the glenohumeral joint, what motions of the shoulder, in terms of going forwards or backwards, side to side, or rotation, would be bisected or cut in half by that sagittal plane? And nobody's probably going to know the answer to that because I think I asked it in a nonsense way. So I'll just tell you. So we're going to pretend there's this imaginary line that runs straight up and down, kind of like a paper, through the middle of my shoulder. So if I do shoulder flexion, which is this, that sagittal plane is going to divide the humerus, going to divide my arm in half throughout that entire range of motion. So that's flexion, that's extension, coming straight back. So flexion and extension then are said to occur in the sagittal plane. Okay? So that's going to be an important thing to know. So flexion, extension, and flexion is spelled F-L-E-X-I-O-N. And then you know how to spell extension. So flexion and extension occur in the sagittal plane. All right. So I've got two other pairs of movements that I can do at the shoulder. So I can move my arm straight out to the side, or I can bring it back to my side. And I can rotate my arm internally, so I can take the front of my arm, or the front of my humerus, and rotate it toward my midline, or I can rotate it away from the midline. So which of those pairings, this is called abduction, bringing your arm straight out to the side. This is called adduction, bringing it back down to the side. And then this is internal rotation, this is external rotation. So which of those pairs would occur in the frontal plane? So again, the frontal plane is going to divide me into front and back. Which of those motions, ABA deduction or internal external rotation, is going to be divided in half throughout its entire range by the frontal plane? Very good, ABA deduction. So that's another important thing to know. ABA deduction occur in the frontal plane. And then process of elimination, our last two motions are, at least in the shoulder, are internal rotation. So again, you take the front of your humerus, rotate it toward the midline like this. And external rotation, take the front of your humerus, rotate it away from the midline like this. So internal, external rotation, the arm is cut in half throughout the entire range of motion by the transverse or horizontal plane. So your rotary motions then occur in the transverse or horizontal plane. All right. So a related concept is this thing at the bottom, degrees of freedom. So one of the things I'll ask you about different joints, so the glenohumeral joint, again the shoulder joint for example, will be how many degrees of freedom does that joint have? And what that question is really asking is in how many planes, sagittal, frontal, transverse, in how many of those planes does that joint move? So we just showed that the shoulder joint, the glenohumeral joint, can move in the sagittal plane with flexion extension. It can move in the frontal plane with ABA deduction, and it can move in the transverse or horizontal plane with internal and external rotation. So how many degrees of freedom in how many planes does that joint move? 3, right? So it's got 3 degrees of freedom. All right, let's pick a different joint. Let's do the wrist joint, so your radiocarpal joint. So what can I do at my wrist? Yep. Yeah, good. So you can do wrist flexion, which is to bring the palm of your hand closer to your forearm. And then if you can do flexion, you can do extension. So you can go the other way. So like if you fall and catch yourself, that's wrist extension. All right, so you can do flexion, extension. What's the plane on that? Sagittal. Almost always, so we're using the shoulder right now, but almost always they're going to be the same. It gets a little bit different like when we talk about the thumb and some other joints like that, but for the most part, they're all pretty much the same. So flexion, extension in the wrist is sagittal plane. All right, what else can I do at my wrist? So you got one more pair of motions. Yeah, so you can do what's called ulnar deviation. So you bring the pinky side of your hand closer to your forearm, or you can do thumb side of your hand closer to your forearm. That's called radial deviation. So I can do ulnar deviation and radial deviation. And you'll see I jump back into anatomical position as I'm doing those. So in what plane do those motions occur? We know it's not sagittal. Good, frontal, yep. So frontal plane. All right, can I spin at my wrist? Can it rotate around itself? Not unless your wrist is really messed up, right? So can't do that. So how many degrees of freedom does the wrist or radiocarpal joint have? 2, yep. Because remember, so it's 2 because we can move in the sagittal plane and the frontal plane. All right, and then go to, I'm trying to remember to narrate enough that people listening to this later will know what I'm talking about. So go to the farthest knuckle on your pointer finger. All right, so that's called your distal interphalangeal joint of your second finger. All right, what can I do there? Flexion, extension, that's all I can do. So I can bend my finger and I can straighten it. So in what plane does that occur? Sagittal, good. All right, can you ABA deduct at that joint? Again, not unless it's really messed up. Nope, so you shouldn't get ABA deduction there. It shouldn't move side to side. It also shouldn't spin on itself. So because all I can do is flexion, extension, how many degrees of freedom do I have? 1, good. One of the things I'm going to do on the test to try to mess you up, because, you know, why not, is on a degrees of freedom question, I'll say, okay, if you've got the radiocarpal, the wrist joint, how many degrees of freedom does it have? 1, 2, 3, 4, or 180? And if I give you some really big answer like 180, what I'm hoping, or what I'm thinking you might do, is confuse the concept of degrees of freedom in terms of number of planes with the concept of range of motion. So we can measure a joint's range of motion, how far does it move in terms of number of degrees, like you do something spinning around an axis, right? So in the case of the shoulder, if we move from full extension, so bringing the arm straight back, to full flexion, that's more than 180 degrees. So that's degrees of range of motion, which we're not going to measure, and I won't ask you about. So just know, if there's a question about degrees of freedom, the answer has to be 3 or less. If there's some answer on there like 90, 180, 360, whatever, that's the wrong answer. So it has to be 3 or less. All right, let's make life even more complicated. So those were the planes, or the planes of the body, and then motions occur in those planes. Now, let's talk about axes of rotation, or axes of motion. So just like with planes, so one of the ways to think about axes, so just like with planes, there's three of them. So one of the ways to think about axes are they're kind of like these imaginary bars that run through the body. And so when I say bar, think about the tamping iron that we had last time, right? This long metal rod. So each of these axes is kind of, again, like a long metal rod that's running through the body, one direction or another. So you got three axes of rotation. There's the bilateral, or x-axis. And so the x-axis, if something's bilateral, bi means two, lateral sides. So something bilateral is both sides. So if you have a bilateral ailment, it's affecting both sides of your body. In this case, the bilateral axis runs through both sides of the body. So it runs right, left, right, however you want to envision it. So it is this axis here. So it's also referred to as axis. So usually I'll refer to them by their letters, because I think it's easier to envision them when referring to them by their letters, because you can think back to your geometry class and graph paper, right? So you had your x and y axis on the graph. So your x-axis runs left to right. X-axis in the body runs left to right. The y-axis on your graph paper runs straight up and down. Same thing in the body. The y-axis is this imaginary bar that runs through the body straight up and down. And the z-axis is, if your graph paper was 3 dimensions, the z-axis would come straight out of the paper. So the z-axis, its alternative name is antero-posterior. So remember that anterior is front, posterior is back. So antero-posterior means front to back. So it's an axis or an imaginary bar that runs through the body front to back. So osteokinematic motions, so things like flexion, extension, abduction, internal rotation, etc., all of those also occur not only within a plane, but around or about an axis. So if we twisted one of these bars, so we'll take this z-axis, and if I twisted it to my right, his left, he's going to rotate in his trunk, right? So if I take this imaginary bar and I rotate it, twist it, he's going to turn with that thing, right? So an easier way, I finally found a decent graphic. So these are the three axes running through your shoulder, so running through the glenohumeral joint. And they're color-coded to make life easier. So the x-axis is this green one. So that is the bilateral x-axis. So it's running through the shoulder joint left to right. So that x-axis backwards. What's going to happen at the shoulder joint? What motion am I going to get that we've already talked about? Flexion, very good. So if we rotate that backwards, we're going to get flexion. All right, so then if I rotate it forward, then I'm going to get extension. So flexion and extension at the glenohumeral joint occur around or about the x-axis. Another important thing to know. So flexion and extension occur around or about the x-axis. And so again, you can see this. Again, this one's color-coded. So you got the green x-axis here, and then you've got flexion extension with the green arrow here. The antero-posterior, or z-axis. Again, that's going to run front to back. So it's going to run straight through the shoulder joint, front to back. So if I twist that to my right, your left, what's going to happen to my arm? Abduction or adduction? Abduction, good. And if you go the other way, then you get adduction, right? That's our z-axis. So antero-posterior, or z-axis. All right, and then process of elimination, the y-axis, the one that goes straight up and down through the humerus, if we rotate that right or left, we'll get internal and external rotation. So internal, external rotation occur around or about the y-axis. So what you're going to want to do then is to memorize the pairings. Because if we say that flexion extension occur in the sagittal plane, the axis that flexion extension occur around or about is going to be the one that's perpendicular to that, the one that's at a 90-degree angle to that. So flexion extension then occur in the sagittal plane and then around or about the x-axis. and then ABA deduction occur in the frontal plane around or about the z-axis, and then rotation, transverse plane or horizontal plane, and then the y-axis. So like I said, if you forget, it's coded on the so that you can match them up pretty easy. The colors are kind of subtle. The green and blue kind of blend, but they are on there. All right, so let's talk about divisions of the body very briefly. So the body has divisions, and those are the axial division, and we'll talk a lot about the axial skeleton toward the end of class, but the axial division of the body is the head, the neck, and the trunk. And then the axial skeleton that we'll get to at the end of class includes the bones that are involved in those. So it includes the skull, your spine, your ribs, your sternum, and your pelvis. So the axial component of the body, or axial division of the body, is the head, neck, and trunk. The appendicular division, or your appendicular skeleton, deals with the arms and legs. Because your appendages are your arms and legs. Appendicular, then we're dealing with the arms and legs. For example, when we get to the shoulder on Wednesday of next week, we'll start talking about your clavicle, your scapula, and your humerus. Those are part of the appendicular, your arm, skeleton. In addition to those, so there are smaller regional terms. We'll get to some, so don't write these down yet. I'll go to the ones, or talk about the ones that are relevant as we go along. But just so you know, there are divisional terms or smaller regional terms that we can talk about. So for example, one of the things we'll talk about a lot in the hand and wrist, we use pollex a lot, which is your thumb. So anything pollex deals with the thumb. So for example, you've got abductor pollicis, extensor pollicis, etc. So anything pollex then deals with the thumb. Similar thing in the toe or the foot, the big toe is called your hallux. So you got hallux valgus as a bunion. So like I said, we'll go over the more specific terminology as we need to when the course progresses. So in terms of planes of the body, the only other place you might encounter them other than describing movements is medical imaging. And so you can see different types of medical imaging between the functional MRI, the CT scan on the far right. But what those do is they slice the body into about dime-sized slices to get views of particular organs or joints or ligaments or whatever it is that they're interested in looking at. They slice the body along those planes. All right, so as mentioned earlier, we'll talk briefly about body cavities. So body cavities, obviously a cavity is an opening. And so these particular openings in the body are actually closed to the external environment. And they're full of something. Depends on which cavity we're talking about. But there's something in there. But they are openings in the body that are actually closed to the external environment. So for example, you can see broadly speaking, there are two sets of body cavities. There's the dorsal body cavity and the ventral body cavity. And they're color-coded. The dorsal body cavities are yellow. Ventral body cavities are kind of a reddish color. So again, dorsal is on the back. Same thing as posterior. One of the ways that I remember that when I had to remember dorsal and ventral, the dolphin's dorsal fin is on its back, right? Or a shark if you're into more aggressive animals. The shark's dorsal fin is on its back, so anything dorsal is on the back. All right, so the dorsal body cavities, there are two subdivisions there. There's the cranial and vertebral cavities. So the cranial cavity, obviously your cranium is your head, right? So the cranial cavity then is the cavity inside of the skull that houses your brain. The vertebral body cavity, your vertebrae are your spine bones. So the vertebral body cavity is the opening that runs lengthwise up and down your spine that houses your spinal cord, which is the bundle of nerves that relays signals to and from the brain. So cranial cavity houses your brain, vertebral cavity houses your spinal cord. So those are the dorsal body cavity, or those two make up the dorsal body cavities. And then the ventral body cavities, so you got two subdivisions there, thoracic and then abdominopelvic. So the thoracic one is the one that's more superior, so it's closer to the top. So that anything thoracic is inside of your chest. So the thoracic body cavity is everything inside of your rib cage or inside of your chest. And it's separated from the abdominal body cavity by your diaphragm. So your diaphragm's there, and so now we get into the abdominopelvic body cavity. The thoracic body cavity can be further subdivided. So you've got two pleural cavities. There's a left and a right. So anything pleural deals with the lungs. So you got a right lung and a left lung. So there's two pleural cavities, and then there's the mediastinum, which is kind of this middle cavity. So the mediastinum houses other things, but in particular your esophagus and your trachea. So your esophagus is the tube that brings food from your mouth down to your stomach. Your trachea is your windpipe. And then the mediastinum can be further subdivided. There's another cavity inside of that, which is the pericardial cavity. And so the pericardial cavity houses your heart. So that's all the stuff in the thoracic body cavity, and then you've got the abdominopelvic cavity. So the more superior part of that, portion of that, which is kind of all of this, that's going to house the organs of digestion, filtration, and excretion. So things like your stomach, your liver, your gallbladder, your intestines, those are in the abdominal cavity. And then the pelvic cavity is the organs of excretion and reproduction. So things like your bladder, your ureter, etc., are in there. All right. So one of the things to know about the ventral body cavity, so now we're talking about just the thoracic cavity and the abdominal cavity, is that both of those are lined by what's referred to as a serous membrane or serosa. So serosa is oftentimes used as the plural. And so what the serous membranes or the serosa are, they're a type of tissue called epithelial tissue, which we'll talk about more in PEPROF 202. But they are a tissue that lines the inside of the cavity as well as the most superficial surface of the organs inside of that cavity. So it's basically a two-layer membrane. So one of the ways to envision it that this book uses and many anatomy books use is to think about if you've got an underinflated balloon, or a water balloon is actually probably a better example. So not a fully filled water balloon, but it's kind of loose. And so if you take your fist and you kind of push it down inside of that water balloon, again, there's basically a two-layer membrane there. So to the parietal serosa. So this parietal serosa is this serous membrane, this layer of cells that is on the inside wall of the thoracic cavity or on the inside wall of the abdominal cavity, either way. And then the second layer of the membrane is called the visceral serosa. So again, that layer of cells that's on the most superficial layer of an organ. And so in the case of the water balloon example, that would be the part of the balloon that is directly tracking. So between those two, if you have a water balloon, you've got water filling in that space. Right? So you've got outer layer of the membrane, inner layer, and then water between the two. And the reason that matters is because that's basically how our abdominal cavities are set up, so that we have we're able to reduce friction when our organs move around. So for example, you can see the heart here. So there's this outer layer, the parietal serosa, and then there's this inner layer, the visceral serosa. And both of the two layers secrete what's called serous fluid, which is just kind of a lubricating fluid. It's kind of like motor oil. So it's a lubricating fluid that helps, again, reduce friction so that when the heart is beating, it's not rubbing up against the surrounding organs, because that would cause tissue damage. So basically, they are surrounded by fluid to help them be able to move. All the time, your lungs are moving all the time, but that extends into the abdominal cavity as well. So your stomach has to be able to expand and contract, and it also goes through a series of rhythmic contractions as you digest. So the stomach's moving pretty consistently as well, as are your intestines. And so to keep them, again, from rubbing on the organs around them, they also have this two-layer membrane called the serous membrane. All right, so I have a case study for you. So we're going to pretend that you are a high school cross-country coach, and you're out at practice one day, and your runners, you're not going with them because, But you're watching him run, and you notice that one of your senior male athletes, is just not able to keep up that day. Like, he's just doing really terribly. He's running slow, can't keep up, and eventually he just stops and starts walking and then sits down. So you're like, oh, something must be wrong. And so you go out and talk to him and say, okay, well, what's going on? And he says, well, I can't keep up today. Like, I feel like I just can't catch my breath. I'm really short of breath. I have this really sharp pain on the left side of my chest with he won't say sudden onset, but like it just happened to start hurting really bad, and it's gotten progressively worse. And I feel a little bit lightheaded, maybe a little dizzy. So what kinds of questions would you want to ask your athlete given that scenario? Good, yep. So, I'm normally hydrated. I do what I always do leading up to practice. Good question. What else? Did you stretch? Yeah, I did same kind of thing. Did normal warm-up. Did, let's say, active warm-up, bounding and whatnot. I don't know what cross-country runners do. Run slow and then run fast. Sorry to any cross-country runners. All right. What else do we want to know? So we know hydration status, had normal warm-up. Anything else? Michael? Oh, great question. He does not have a history of asthma, but that is a really good one. Anything else? Has he eaten recently? Yeah, he has. Normal stuff. Had a snack 2 hours before practice, or whatever he normally does. All right. So as you're talking to him, you notice it's getting worse. He tells you this pain is getting worse, and you guys have been sitting there, you've been asking him questions for a couple of minutes, and you notice that his breathing rate has not slowed down. And in fact, it's sped up. So he's hyperventilating. He's breathing really fast, really rapid, shallow breaths. What could be happening? We're going to make it even worse. Now his lips are kind of blue. Let's just keep going downhill. Yep. He does have a collapsed lung. Very good. So the term for that is a pneumothorax, which is what it is. All right, so it spells for you there. So you don't have to know that, but anyway. So he has a pneumothorax. In this case, he has a spontaneous pneumothorax. It just happened. Other relevant questions would be, does he smoke? I was going to tell you no, but if he did, that would make him more likely to have a spontaneous pneumothorax, whether it's smoking tobacco or smoking marijuana or anything else. But the gist of it is, in this age group, so in adolescent males, particularly males who are really tall, so that's kind of why I picked this picture. Got a bunch of tall, lanky guys, or at least this guy is. Build with that age group, they are, I won't say predisposed, but they're in the likelihood to get something called a bleb, B-L-E-B, it's a fun word, on the lungs. And basically what that is a little, it's kind of like a herniation of the lung. And so if that ruptures, now, every time you breathe in and out, should be serous fluid out there. But if they accumulate. And so as it accumulates, which is what you can see on his left side, as that air accumulates, it's going to keep the lung from expanding. So if the lung can't fully expand, it can't oxygenate the blood that's going through it. So your oxygen saturation is going to go down. So normally you're going to have, give or take, 98% oxygen saturation. That's going to go down progressively, 95, 93, etc. And so that lack of oxygenation of the blood is what's going to produce that dizziness sensation that he's describing to you. And as the blood gets progressively less and less oxygenated, because you can't inflate the lung, then it changes the color of the blood a little bit. It makes arterial blood look more like venous blood. So it takes on more of that bluish tint. So that's why his lips would eventually turn blue. That's why his nail beds would eventually turn blue, is he's not getting enough oxygen into his bloodstream. So what do we do about that? Now that we have realized, uh-oh, this guy might have a collapsed lung. What do I do? Tell him to rub some dirt on it? I'm smiling, but you can't see that. Obviously, this one's an emergency. You're going to want to go ahead and call 911. The ambulance will come out, and then one of the things that they're going to do is actually put a tube in there to drain that air out, and then the lung will inflate. So typically, the outcome he's going to keep hyperventilating. You're going to continue to get decreased saturation of the blood. And then eventually, if it progresses far, it'll actually push the trachea over to the opposite side. So if it's, in this case, I said left, but in this case, this is a right lung. it'll push the lung or the trachea to the opposite side. So you'll get tracheal deviation where it's shoved over here. So that's pretty much end stage. That's bad, as you can imagine. So that's where the serous membrane comes in. Again, so it should be all fluid out. If something happens to disrupt those serous membranes, then you can get something like this, a pneumothorax. You can also get that with sort of like a penetrating chest injury, or with a rib fracture, you'll get that as well. And then similarly, you can get something like that in the pericardial cavity. So you can get problems where pericardial cavity with really severe chest injuries. All right. And then last thing for today, abdominal pelvic quadrants. So these are more for those of you interested in medical stuff. So the abdominal cavity can be divided into quadrants. And again, primarily you're going to see this related to medical diagnoses. Effectively what you've got is an imaginary line. It's that sagittal plane that runs straight through the belly button, divides us into left and right. And then we've got an imaginary line, a transverse plane that also runs through the belly button, divides it into top and bottom. And so where this comes in handy is it helps you envision what organs are in each quadrant. So for example, the right upper quadrant, we've got our liver, gallbladder are the two big things in there. Your stomach crosses over a couple of them, obviously. The left upper quadrant, that's where your spleen is. So when athletes have mono and they can't participate in contact sports because they might rupture their spleen is in the left upper quadrant. So if they get a spleen rupture, they tend to have left upper quadrant pain and then left shoulder pain. We'll talk about referred pain later. Similarly, so left lower quadrant, not a lot going on there. So you got your parts of your large and small intestines in there, half of your bladder's in there, but there's not a whole lot going on in the left lower quadrant. The right lower quadrant, a little bit more interesting. Out of curiosity, anybody know what this thing is? Appendix, good, yep. So your appendix is there. So in terms of quadrants, where those come up most often that people are familiar with is appendicitis. So appendicitis, you get an inflammation of your appendix, which is part of your large intestine. Somehow it gets blocked most of the time. And so what ends up happening is the athlete comes in, and I say this as an athletic trainer, the athlete comes in, and they typically complain of low-grade fever, about 99, that's been going on for a few days, that they have no appetite, and that they have started to be nauseous, and maybe they've progressed to vomiting by the time they come to you. And they also tell you they got pain kind of down here in their abdomen that becomes increasingly more localized. So appendicitis, once it's getting close to rupturing, typically presents an area called McBurney's point, which is halfway between your belly button and this flat part of your pelvis called your ASIS. So my McBurney's point's right there. So if they've got localized pain there, plus all the other things I described to you, you should probably go to the hospital. So that's where the quadrants come in, is diagnosing if somebody got tackled or speared or something, and they've got pain upper right quadrant, maybe they've got a liver laceration. Unlikely, but it does happen. So, all right. So any questions on any of that stuff or anything else? So we've met for 2 whole days, and now we get a long layoff. So I won't see you again until Wednesday of next week. But on Wednesday of next week, we'll start talking about the shoulder. So bring some coffee and be ready to talk about bony landmarks. So we'll see you on Wednesday.